we have another stalwart. He is a teacher and a magnificent teacher. He has rolled out resident batches after residents, and he is going to tell us about the IOL dislocations. So when you have a subluxated bag, you have done a good job and you think you are done well, and finally you see that the IOL is out of place, what do you do? Minu, MATHEN.
Thank you, sir. Good afternoon, ladies and gentlemen. Thank you for this opportunity, Partha, sir. SICS, as he said, if we know SICS well, it's a good bailout. So as he said, underline the point, learn SICS well. Don't have, partially done few cases and this at this stage, I'll just do SICS and take it out, won't work. Okay, and some IOL dislocations, no financial interest in this. My resident, as he said, doing this case with a PC rent here. Aspirating vitreous nicely. I told her, place it into the anterior chamber, we'll place it. But invariably, even if you want to place it in the anterior chamber, most of these lenses will directly go into that area. I told her, get a forceps and hold it. She's trying to see the hands shaking and all those, and then again asking nurse, where is the forceps? By that time, it says bye-bye and it is gone. So, remember, if there is a large rent and if you want to place it somewhere where you want to, place it in the anterior chamber, fix up, and then gently place it where you want to place it. So, this is the problem. Adrenaline, when it comes, you don't know. So, this is a 20-year-old surgery, younger person, traumatic cataract, decentered IOL. And you see, this is an open area here. And this lens is a large lens, but still decentered. See the deformed haptics. So, I find that this opening is there. So, I do a vitrectomy and then cut open this opening. The rest of the bag is fine. Inferiorly, there definitely must be zonular loss. That must be the reason for this one. So, I was scared if I cut too much of this fibrosis, the bag may just give way. So, I just nicked this area, made it larger, placed a 13 millimeter three-piece lens there, and saw that how to optic capture this. See, then it was not so very large enough to optic capture. So I took my bold decision to cut the fibrosis, but nothing happened. So if you have your cut ray slightly lower and then munch it very well, you can cut these ones and then see the way I can posterior capture on this. So it easily goes in. There is no extension at all. And it is snugly fit. So these things, if you release, it is all going to be messy and you have to release the whole thing. See the pupil constricted and the P1 and P2 are overlapping and it is fairly well centered in the bag. And so minimal manipulation. Yeah, next one. Minimal manipulation will be the best deal. Again, a decentered IOL for some time. Patient is complaining of glare. So why is it so? Constricted the pupil, see the iris which is retracted to one side, fibrosis here. So that edge is coming in the pupillary area and that is causing his problem. So, but if you keep the eye straight, the Purkinje images are on the optic. So I decided to correct this by minimal, I'm talking about minimal manipulations or for these kind of problems which can get you through. So you do a pupilloplasty here and bring down the pupil and open this side of the pupil a little more, and then this IOL is still in the visual axis in the pupillary area and the pupil becomes smaller, and make sure that your Purkinje image is still in the center of the pupil. If that is so, you can get away with this, and patient did not have, he had 6/6 vision. Only problem was his glare because of the iris being retracted to one side and the slight decentration of the IOL. So this is the 4th row pupilloplasty, 9O or 10O Prolene, 4 rows on this loop, 2 bites on the iris here. And then retract this, 1 knot is enough. 4 knots, 1 knot is enough. You don't have to retract back, make again 2, 1, 1 and all those, not required. So if it becomes too small and you want a little more of the pupil, you can extend by doing a little vitrectomy on the pupillary margin or a sphincter cut with your scissors. So this is his case. He had played such a large dialysis and CTR, and patient came back to me after 1 year like this, So if they are so loose, it will be like this. After them, they'll come back to you, or you can send them to one of your enemies. Yeah? So anyway, I open up the pupil, very important, visualization. And then viscote above and viscote below. There is a CTR, there is an IOL. So this is just floating in the AVF. So now I make 2 flaps, 3 millimeter flaps, because I want to make 1 millimeter sclerotomies. And then this needle, now I have shifted to Gore-Tex. This was a little early, and this is 90 Prolene. So this 26 gauge needle comes behind, and when it comes over the iris, actually you need to tap this complex down, put viscoelastic and lift up the iris so that the second pass comes over the bag complex. The first one was through the bag, and so a loop will catch it, and the other side also you can don't tighten or knot the knot first, one knot, both make slip knots and tighten it according to the centration of the lens and then complete it. This is again minimal manipulation. Question can be, why don't you just remove the whole thing and do a scleral fixation? Well, fine. But this is with minimal manipulation, this can also be done. So my last thing is, Somshila showed iris claw and nothing wrong with iris claw. This is one iris claw which was on the retina. So iris claws can also dislocate and go on to the retina, and retina person happily brings it up. So I don't believe in iris claws, so I do only scleral fixation. So I wanted to get this thing out. So he brought it up. So see, please see this coming up. And then one claw came up and the other claw is coming up. And he is pushing this one and coming inside. So there is a little pupil peeking, if you see. And then I am called, so I make a 6 millimeter scleral tunnel and then enter and identify this one. He said, IOL is there, you pull out the IOL. Now I realize that when I move the IOL, the pupil is also moving. So this iris claw has been clawed back again. See, this is what has happened. So iris claws are always waiting to see iris somewhere and to catch the iris and claw it. So when he brings it also, it was staying there. And for remembering that the iris is still there, it's going and clawing itself into the iris again. So this got clawed in, so it was just at the edge of the pupil. So I just cut the snipped the iris off and took it out. Other way is to snip off one claw. Cut off one claw and then it becomes free. Or you can just use both hands and then open it up and then snip out. That's all more difficult. The cornea is bad here, so we don't want too much of manipulation inside. And this is, if this is enclaved here, I would not do this. Otherwise, you will get a large hole on the iris. Because it was enclaved when it was coming out through at the edge alone, I just snipped off the iris and took it out. And there comes the iris claw. Still won't leave iris, see, still holding on to the iris. So iris claws, as Somshila said, it will hold on to the iris very well. If you have not enclaved well, then it will drop like this. So make sure you enclave well. Then the next horror show is that I find that there is posterior capsule 360 degrees under the iris. So in panic situations like PCR and all, so you just show in some IOL, see, and then I place, while talking about this, this is going. This IOL was placed on the anterior capsule margin, but then when I held this, this is again going down. So pupil expansion and pupil dilatation visualization when you are doing all this is very, very important. So when I put the iris hooks, I identified that this haptic has gone underneath the capsular rim. So again, visualization very important, retracted it back and then lifted it over the anterior capsule and place it over 360 degree, there is anterior capsule rim. And then that is placed into the sulcus and the second haptic is dialed in and it is placed in position. We need to tap it and see whether it is bouncing back into position. Sulcus, sometimes it may be, sulcus may be little different in size and orientation, you may have to change. So now it is very well stable and this is centered. Thank you very much.
Thank you very much, Minu. So questions for Minu? Yes, Dr. Professor Madi, yes, please. Oh, you need to go? Oh, surely, why not? Please, please. Any questions for Minu?
There are different ways of doing handling all these cases, but these are some ways you can get away with minimal manipulation. Secondarily, when you go inside, it's better you don't manipulate too much if you can get away with the. So
Minu, about the safest way to do a secondary implant. Again, because the safety is something that is debatable, but right from the iris claw, where the possibility is, as you said, the disenclavation can occur at time, to the fixation, the secondary IOL fixation with sutures, where again fraying of the sutures at any point of time. And third, the use of Gore-Tex. So the use of Gore-Tex, how much have you inculcated in your practice? Because Gore-Tex is one suture that will last a lifetime.
So now if I have to suture a back complex or a secondary IOL, I'll use only Gore-Tex. But my use of that has come down to a very minimal thing, just like this case with the CTR and a lens in the back and you have to fix it. Or an aniridia IOL if you want to suture and fix it. These are the two situations I'll use a Gore-Tex or a suture. All the other cases I'll use, I'll remove the whole thing and do a glued IOL.
I think Gore-Tex is a little overhyped. You can use 9-O-Proline. See, the paper about Proline sutures getting frayed was on 10-O-Proline. 9-O-Proline stays for lifetime. It's Gore-Tex is a little bit of hype. It's a little bit, and it's very difficult to handle also. The suture is a little difficult to handle.
So
if
She
you
might
don't
tell
have
you. She might tell you
access-
how to handle Gore-Tex.
Yeah, so,
Yes.
so Sunfike is a different surgeon. Okay.
but I think
She
you
will
know,
teach all of us. Yeah.
Oh, yeah.
It's important, Professor Chi, if you can tell us how to handle the Gore-Tex, because when you're handling Gore-Tex for the first time, it can be really difficult. It can be very messy, and you can really think that why did I do it at all? Because of the thickness of the material, the stiffness of the material, which we are not used to when we are handling 9-0 or 10-0.
Escape from full screen. How do I escape from the full screen?
Any other questions we have? Yes, please. Yes, please. No, we really want everyone to participate, because we have kept the talk small so that the participation can be more.
Stop.
There are places in the front. You can please come, sir. Sir, you can keep come to the front row, sir. There are places in the front. Yes, please.
Sir, in this case, because it was closer to the pupillary margin, we just snipped off the iris while removing the iris claw. But routinely, what is the method of disengaging an iris claw lens from the iris?
Okay. Minu,
As I told you, no, as I told you, we can do it in two ways. One is to cut one of the claws, just like with your banana scissors, or if you have a IOL cutter, you can cut one of the claws, and then there is a lot of gap, and it can easily come out of your enclaved area. Other thing is to try to manually pull. That is very technically very much difficult. And if it is only a very minimal area which is enclaved, and there might be lot of tissue loss and fibrosis and all those, you can make a small nick on the iris. It will act like a PI if it is beyond mid periphery. But if it is a large area which is enclaved, and if you cut through, it will become like a large iris hole.
So where do you cut the claw actually? If we cut the claw, then the iris claw cannot be used again to
No, you're not planning to use the iris claw again. You have a backup of another IOL, and if you're explanting an iris claw, that iris claw is gone. Don't reuse that iris claw lens.
Sometimes while implanting the iris claw, a beginner surgeon might implant it closer to the pupillary margin than how much it has to be going away towards the periphery. In such situations, we might have to disengage the iris claw.
These are the ways I know. Yeah.
Okay, I'll answer this question, Minu, because we have an experience of the phakic IOL, the iris clip ones, the artisan as well, where you have the crystalline lens below. So you have to be we have to be very careful. So I'll just tell you one or two small tricks when implanting the iris claw. The first thing is the iris claw has to go in seamlessly without any pressure. Here, of course, it's a aphakic eye, so you have a very large chamber. So placing it in and having the incision a little larger than the optic size. So it goes in, you rotate it, okay? And then the special enclavation forceps is very important because it has a curvature to it. If you don't have that forceps, it can be very difficult and you will not get the right plane for the lens to go in. So that's point number 2. Point number 3 is when the lens has gone into place, then you have to predetermine from where the enclavation spatula will go in. Now the enclavation spatula is also something that is quite important, and it does not have a rough edge. It just has to enclavate on the clip of the claw. Now that has to be done as a different port than the port of your IA. If you want, you have to do an IA. So that port has to be different, and that port has to be right from the side. Means, say you're operating on a right eye, then it has to be, one has to be at 2 o'clock, the other has to be at 11 o'clock to 10 o'clock. Okay, so that spatula has to go in straight and then enclavate. Okay, so these are a few tricks. Now when you're disenclavating, then again it is again very simple. The pupil, you have dilated it, the pupil is you have placed the forceps properly to grasp the optic, and then disenclavation is again by that same spatula, and the iris tissue just goes out. So it's not so difficult at all.
I'll answer your question. Actually, specifically, you wanted to ask about disc inclination. How does the iris claw hold? There's a gap, you have inclinated. It's almost supposed you have parted it slightly and inclinated the iris. Now, if you are going to try to pull them apart, it's PMM, it's going to break. Change the plane. Create a gap over there. So use a forceps or whatever to just hold one and push the other down. You create a gap, the iris will